to today's discussion about urban health in India. My name is Gib Clark. I am the Program Associate with the Global Health Initiative here at the Woodrow Wilson Center. For those of you who are here for the first time, I'll just tell you a little bit about the Wilson Center. The Wilson Center was started in 1968 by an act of Congress as the living memorial to our nation's 28th president. As Wilson was our only president to have earned a PhD, the Wilson Center aims to bring together the worlds of ideas and policy. The Global Health Initiative, which is presenting today's event, is about a year old. It was formed in response to the fact that among our 20 or so programs and projects here at the center, nearly all of them were looking at health in one way or another, so the center wanted to have a program that would be able to house all that information, but also look at a few other things that weren't being covered, and included in that are four main elements. The first is health's impact on development, the role of international and national institutions in global health policy, infectious disease, and emerging health technologies. For today's event, we're lucky to have three excellent people here with us today. The first is Dr. Vic Barbiero, who will be moderating the event. Dr. Barbiero is a visiting associate professor at George Washington University and is also, we are also lucky enough to have him as our senior advisor to the Global Health Initiative. So, great to have him here. Dr. Siddharth Agarwal will be making a formal presentation. He is the executive director of the Urban Health Resource Center and is also the country representative, and was formerly the country representative and urban health director of the USAID Environmental Health Project. He is a member of the Government of India's Task Force on Urban Health, and he has over 20 years of experience in medicine, project management, and technical assistance. Diana Silimperi will serve as a discussant. She has over 25 years of experience in maternal and child health, nutrition in Africa, Asia, and Latin America. She served as the Deputy Director, Technical Director for the Quality Assurance Project and has been the Technical Director of the Global Newborn and Child Health Project, also known as BASICS. Maybe she can tell you why it's known as BASICS. So she's been in charge of that since 2004. Much more information, I've left out quite a bit about all three of these speakers is available in the handout that was available outside. Two more notes before we begin. The first is, I apologize, I failed to mention, I was being a little egotistical here, I failed to mention that we are co-sponsoring this event along with our Urban Studies project here at the center. They look at all kinds of urban issues, including urban health. And the second note is that we are webcasting this event, so when it comes time for the question and answer, please wait for a microphone to reach its way to you so that folks watching at home can hear what you have to say. So I'm going to pass it over now to Dr. Barbiero. Thank you, everyone, for coming, and thanks to our presenters.
Thanks, Gib. It's truly an honor to be here, and nice to see everyone here on this beautiful Thursday afternoon. Nice day to go out and ride motorcycles or something like that. As many of you know, urban health has a special place in my heart and mind, and I'm particularly pleased to be here today with two colleagues that I've known for years. Dr. Silimperi and I go back, well, early 1990s, 91 or so, when we first organized an urban health symposium out of the USAID regional office in Nairobi. And she brings a wealth of experience and knowledge from both overseas, from the programmatic side, as well as the technical and clinical side, based on her experience, and knows a great deal about health in general, maternal health, newborn health, but also the key issues relative to urban health, urban care, insurance schemes, et cetera. So a very, very strong and rich base of knowledge. Dr. Siddharth, I'm so pleased to see him again. We worked together in India when we first started the Urban Health Initiative, and I'm so flattered and pleased to see that it's a growing entity in India as well, and so successful in terms of its interventions, and just putting the ideas and priorities of urban health on the agenda if you remember little from this, remember this, that what we're talking about today is inevitable, unstoppable. The momentum is there. The world is urbanizing. These are the sorts of concepts when we talk about this subject that we have to appreciate. And the urban environment itself represents what I like to call the urban crucible, which is a situation of collision of efforts, a collision of situations. Chronic, infectious diseases collide. Poor and rich collide. All these sorts of issues that we face in international health, global health, the problems that we see here in our own inner cities will be exacerbated in a lot of countries. In 35 years, Africa will be 54% urban. India will be the largest country in the world in 50 years in terms of population, and it will be close to 50% urban. Cities of 1 million people are growing. Rates of growth in urban centers exceed 4 to 5% routinely, which translates into a doubling time of between 19 and 22 years. These are the kinds of things that we cannot ignore if we are to be responsible public health programmers in the future. There are opportunities in the urban centers as well as challenges. Certainly people think the urban populations are better off, and on an average basis they are. But if you look at statistics and indications from the poorest of the poor in urban areas, you'll see that these populations are sometimes even worse off in terms of some of the vital indicators. And those are the kinds of things that I hope we'll talk about in terms of the rich discussion that I anticipate will follow the presentation. So I want to just put on the table those brief remarks. I'm sure we'll expand them with our two speakers, but I look forward to such a rewarding and important discussion this afternoon. I hope you all feel free to join in and participate as true colleagues, because that's what it's going to take to address this issue in the future. So without any further ado, I would like to turn it over to my dear colleague, Dr. Siddharth, and listen to this wonderful presentation about urban health in India. Let's welcome him warmly.
Thank you. Thank you, Dr. Barbiero. It's truly an honor to be here and share before you some information about urban health and some program experiences from India. I've tried to organize the presentation in 3 sections, and we will first look at the growing health needs in urban areas. So this is just a phase of urbanization to help us see how urbanization is transforming the world. Here it's represented through trains and people coming and possibly going. So in some way that represents the influx into the large cities. And as probably this is something which all of you have heard, that in sometime in 2007, the world is becoming 50% urban, or has probably already become 50% urban. And in Asia, urban population is expected to increase from 1.5 billion to 2 billion by 2016. Asia, excluding Japan, is projected to become 50% urban by 2025. And the urban population growth, if you compare with Europe, in Asia is very high as compared to Europe. So that just tells us the significance of this issue in certain parts of the world as compared to some other parts of the world. The number of cities with a population of more than 1 million in Asia is likely to increase from 194 to 288 in the next 8 years. Now coming to India, the urban population of India, by the most recent estimate, which just came in a few weeks ago, is 328 million. and it is expected to become about 550 million by 2026. And if we look at the demographic transition in India, the population growth can be considered as a 2, 3, 4, 5 phenomena. If we look at the census of 91 and 2001, in this decade, the overall population grew at 2%, the urban population at 3%, the large cities at about 4%, and slum populations grew at about 5 to 6%. So it's worth noting that the slum populations or the urban poor populations will be the fastest growing segment of any country's population, particularly these developing countries. In India, urban poor are estimated at approximately 80 million to 100 million. It's always difficult to estimate these numbers because they live in all sorts of settlements. There's no perfect way to count them. So these are different estimates, but possibly it could be higher than this. And if you look at public health and just try to estimate the number of births taking place among the urban poor in India, there are over 2 million births that take place among the urban poor. And we've calculated this based on a crude birth rate of the average urban population of India, and the crude birth rate of the urban poor is in all probability higher than this, so this figure could actually be about 2.5 million. We traditionally associate urban populations with large cities, but if you look at a distribution of the population across different sizes of cities, it is worth noting that even smaller and medium-sized cities have a very sizable urban population in India, because the sheer numbers of those cities are many, and these cities are also growing very fast. Now, in India, there are some states which are lesser developed than other states, and I thought I should just bring this up, even if this acronym may not be familiar to many of you. And these states are called the EAG states. They were defined by a committee set up by the Government of India, which was called the Empowered Action Group, or EAG for short, and that is how they just get that name. And they were defined based on weak socio-demographic parameters. And if we, these states are Uttar Pradesh, Madhya Pradesh, Bihar, Rajasthan, Odisha, Jharkhand, Chhattisgarh, and Uttaranchal. And the point worth noting here is that 43% of India's urban poor live in these 8 states, which are 8 administrative units. Overall, the country has 29 states and 6 union territories. So if you focus attention to these 8 administrative units, which can be administered through the state governments, you will be able to address most of the problems of the country with respect to urban health. Now we'll briefly go over some data that Dr. Barbiero talked about, the urban averages versus what the urban poor have. The usual form of demographic health survey data that we see is urban versus rural, which is what this slide shows you. And the urban is far better. This is about under 5 mortality. But when you disaggregate this urban by the standard of living index, which is an asset-based index used by the DHS, which in India is called the National Family Health Survey, we note that under 5 mortality is not very different from rural populations. And just as a contrast, the infant mortality among the urban poor in India is 66, and among one of the poorest neighborhoods in New York, which it is 11 per 1,000 live births. So that is also a contrast that is, worth noting. Similarly, when we look at undernutrition, average data gives the impression that rural poor, the rural population are worse than urban population, but the undernutrition measured by weight for age among children under 3 is even worse than the rural areas among the urban poor, possibly contributed by the poor environment and poor sanitation conditions, which can contribute more diarrhea, more fevers, and other waterborne infections. That could be one of the contributory factors, in addition to other issues like poor feeding practices and food insecurity. Access to services, we may assume that there are hospitals and many of them, and therefore the urban populations would all be accessing services. But it is worth noting that the institutional deliveries among urban poor in India are only about 42%. So there may be a hospital and a slum dweller or a slum family living only 10 minutes away, but may still be delivering at home because there is no access in terms of social access to that hospital. In the lesser developed states, we just talked about the states which are home to 43% of urban poor in India. The conditions are far worse than the other states in the country. So this is one more reason why the lesser developed states probably would require more effort and more attention. And it is also worth noting that urban poor contribute sizably to India's growing economy, which we read about a lot in newspapers. We probably read about India as a growing super economic power. We read about the increasing number of millionaires in India, but there is also an increasing number of urban poor, and many of them are actually contributing to this economic growth through the informal sector. I'll go over 8 challenges here which a program team or any national government would face in improving health of the urban poor. The first challenge, which Dr. Barbiero also mentioned in the beginning, is a lack of policy focus. You know, India has been traditionally a rural country, and everybody is grown up like that. All the people who are in power, when they went to school, they used to read that India is a rural country. So I think that has contributed to the continued rural bias. Also, there is lack of data about urban poor, and because of fewer studies, there is probably still lack of consensus about the data. The third dimension in the policy gap is the issue of illegality. Many of the slum dwellers live on land which they're not supposed to live. So that also compromises their ability to receive services. And in some ways, there's a need to address this so that the illegality in terms of residence does not come in way of a baby receiving polio drops or immunization or health care. The second challenge is that a large proportion of slums remain invisible or uncounted. We have studied many cities. Here we have pulled together the slums and the estimated populations from 4 cities: Agra, Dehradun, Bali. Bali is a small city of about 400,000 population, about 40 minutes from Kolkata, and Jamshedpur, which is the city famous for the Tata steel industry. And if we pull together this data, there were 452 slums on the official lists with a population of about 800,000 and 328 which were not on the official list, and they had also a sizable population of about 500,000. So it's important to note that if these populations get missed out in planning, then our programs will be standing on very poor foundations. The third challenge is inadequacy of services. As I mentioned, India has remained rural, so our health system is also very rural focused. We have a very well organized health system. It may be less efficient than it should be, but there is a health system for rural areas, while there is a major gap in the urban areas. According to the government norm, there should be a primary care center, which is called a UFWC, which is an Urban Family Welfare Center, or a health post for about 50,000 population. But if we calculate the total number of health posts and the urban population, we will find that there is one health post for about 2.23 million or 230,000 population. So this is a huge gap. And also absenteeism, inconvenient timings, and apathy of the provider also contributes to poor services. ICDS, which is the Integrated Child Development Services. It's an important health and nutrition program at the grassroots level in India. This also leaves out about half of the slum population so far. And another gap in the services is that there continues to be, both in the public as well in the private sector, a greater focus on curative care because it is attractive. A politician will be very happy to inaugurate a hospital, but will not be happy to come for an outreach clinic where women and children receive services. So that also contributes to the gap in services. The fourth aspect is that the services and the coordination among service providers is also weak. And there is a lack of capacity because there are not many examples of urban health programs in India. All the big examples that are even taught in public health schools like Jamkhed are rural examples. We so far don't have an urban health case study being taught at Chapel Hill or any other public health school, and they're not even written up in textbooks. So that also contributes to a gap in terms of a challenge, because if you don't have enough experience, the confidence of people who want to take this up will also be low. Weak referral mechanism is the fifth challenge. There is low access of the public health services, as we mentioned. There is a weak referral linkage from the community as well as from the primary service to the hospital. There are lack of risk pooling measures or some sort of a health insurance for the poor. There is a health insurance which the rich can afford in India, but some risk pooling, some innovative ways to make it affordable to the poor who may be earning something like $2.50 a day or $2 a day would be something which is required. And often there is a high usage of the hospital by the middle class and the higher income group because they have more negotiating power. They can call up their friends and seek an appointment. So that also compromises the hospital's ability to serve the poor. The community level challenges are also there. There is low awareness about services. Many of them are migrants. They do not know that city very well. There is low awareness about health behaviors. There is weak community organization and social cohesion. In urban slums, the social cohesion is far weaker than in most rural areas, and that contributes to a weak negotiating capacity. They will not be able to come together and collectively talk about some issues generally. And to the mother, often there is lack of family support. In most cities, these families are small nuclear families, and therefore if a mother has delivered and she does not have any support, or if someone from the native village can come in only for 5 days, she may have to resort to going back to her daily wage earning within a month or within a month and 10 days, which is a huge public health challenge. The seventh challenge is actually a combination of many issues which makes the urban poor vulnerable. So I just called it multidimensional vulnerability. And there is irregular employment, the struggle for livelihood. Many people can go for wherever they will get the daily wage and may come back after 2 hours without getting any wage earning opportunity that day. There is low access to fair credit. Many of the urban poor households that I visited, they have borrowed at, can you believe it, 5% per month? We cannot even imagine, but that is the scenario that they live in, because they are in such an abject need for money sometimes, and they are in such a situation that they don't have the capacity to approach a bank. Most of these people would not even be allowed to open bank accounts, because the complicated system of opening a bank account, you have to have a residence proof, and it's all very complex. There is poor access to water and sanitation services, overcrowding, poor housing, and insecure land tenure, which contributes to the vulnerability. And unlisted nature of slums also contributes to the vulnerability, and there is always this threat of eviction. They were never sure that tomorrow there could be a bulldozer just throwing them out of that area wherever they're living. And temporary and recent migrants are often denied access to health care, and also they're difficult to track. Even if there's a well-intentioned program, the whole issue of temporary migration is a complication in itself. There is a lack of organized community efforts, as we mentioned, and social issues like alcoholism, substance abuse, gender inequity, poor education also add to the health vulnerability of these populations. And these are just some pictures of environmental conditions. About 2/3 of urban poor households do not have a toilet, which has a big toll on health. This is about water. I just wanted to show this picture. This is, I've probably shown it several times in presentations. This is a slum in Indore near the airport of Indore, and I asked this child where they get their drinking water from, and this is where he put his hand, and this is the next minute he pulled out a pipe. He said, whenever we have the water pressure, we pull out this pipe and we fill in our drinking water cans. Alongside challenges, there are several opportunities. Through these efforts of the last 4.5 years or 5 years that we've been taking up with the Government of India, there is now a growing recognition of the issue and increasing interest among the government. And two examples which illustrate this interest. There is a National Urban Health Task Force. Of course, ironically, it is under the National Rural Health Mission. And this has submitted its recommendations to the ministry. In all probability, the pace at which bureaucracy works, they should be responding to this report at some point in the next 6 to 7 months. And there is a mission which has been launched by the Ministry of Urban Housing and Poverty Alleviation, which is called the Jawaharlal Nehru National Urban Renewal Mission, or the JNNURM. And this has opportunities for building health infrastructure and basic services for the poor. So while these are opportunities, it's important to note that whenever a government makes an announcement, it does not immediately translate into any reality. So these are still missions that have been launched, but to what extent they will make a difference to lives of the urban poor is still something which we'll have to see and find out. One opportunity is that there's a presence of NGOs, experienced NGOs in most cities. So that is an opportunity. There are more interested people and capable people. There's a growing body of urban poor specific research as interest has increased. We now have more data, more research. And geographical accessibility in urban areas is surely an opportunity. At least we do not have to deal with the issue of remote areas. Now we'll talk about some program experiences and lessons, and this is divided into 4 subsections. The first section will talk about the issue of identifying, plotting, and assessing slums. And we just noticed that there's a sizable proportion of slums that are not listed. So we've tried this out in several cities, starting with the first city. We did this in 2002, 2003. We start with the existing list, whatever that list is, usually available from the municipal corporation, and then interact with local people to find out other slums. There could be other lists available in some cities. There could be knowledgeable people, organizations that have done some work, other programs beyond health or beyond the municipal lists. And the next thing that we do is identify from the people themselves what they think are criteria for assessing vulnerability of a slum as compared to another slum. And people are able to define this. And this is also available in literature. Philip Amis and Dr. David Satterthwaite have done wonderful work on vulnerability. We, of course, tried out something similar to that, but more local, specific to that particular city. And then we identify these slums, start plotting them, collect information from them, and triangulate this information with those same knowledgeable people. It's important to validate whatever we collect because it's very complicated information, as you will see from the next slide, which is actually a map. So if we look, this is a map of Indore where using GIS, I'm just trying to show it is put on PowerPoint, but it will just show you. These are these green dots are the listed slums of Indore. And now you have the red dots, which are the unlisted slums. So this becomes a very powerful tool, and this exercise becomes very important.
What proportion of Indore is slum population?
Indore is a city of about 1.8 million and about 0.6 million. About a third of Indore is slum population. So we have noticed that the city map with slums and facilities plotted becomes a very important planning and monitoring tool. And just to have a clearer view of the map, this is how it would look, with the red dots being the most vulnerable slums, the triangles, the purple triangles, the moderately vulnerable slums, and the green stars, the less vulnerable slums. So this helps you prioritize where to intervene. I'll just give you an example to illustrate why such exercises are very helpful. There was an international agency that was working on a primary school enrollment improvement project in Indore slums. And they conducted a baseline, and their baseline indicated a school enrollment of over 90%, and they still implemented the project. And they spent the millions on that project. The problem that they did not notice was that they were going by the municipal list of slums, many of which had no longer remained slum-like. They noticed it at the baseline, but for some reason still continued to implement the project, and the rest of the slums get ignored. And this has happened over and over again, that the same list of slums gets all the inputs from the government or any other agency, because usually people go by the slum list. We'll talk about three approaches. The first approach is a demand, supply, capacity building, and linkage fostering approach, where the non-government organizations and the community-based organizations of the slums have come together and helped develop this approach. Just to give you a sense of Indore, as Dr. Barbiero just asked me, it's a city of about 1.8 million with a third slums. Health services were inadequate, and there was low demand and weak coordination. So it was in this context that these approaches have evolved. The first approach, where the NGOs and the CBOs or the community-based organizations of the slum work together, is based on the principle that enabling and connecting slum communities to health providers with capacity building support from NGOs is an important and valuable activity. And the community level organizations understand the needs of the slum dwellers far better than professional health workers would. And therefore their involvement as key implementers can help address the issues in a far better and probably a broader way. So this approach has on one side the slum CBOs, which are supported by cluster coordination teams, which were active networks of slum leaders at the time that we started this activity in 2003. So we roped them in right in the beginning so that they can become the implementers. And the idea was to build the capacity of these networks, and slowly, at that time it was more like a dream, to turn them into organizations so that they can continue to be a resource for the slum dwellers of Indore. On the other side, we see the service providers, the health services, private sector, the municipal corporation, and charitable organizations. And the capacity building support was provided by NGO and the Urban Health Resource Center, which was then called the Environmental Health Project. And this has led to, on the one hand, improved community capacity and demand through the CBOs, and improved supply, and therefore improved outcomes, which we will see from data. So we now have 9 of these cluster coordination teams, which we just saw. This is just a graphic to illustrate the cluster. They used to be called lead CBOs initially because they showed some leadership, but they were slum-based networks or community-based organizations. And it is very heartening to share with you that 7 of them are now registered voluntary organizations. And some of them are beginning to get their accounts audited by certified CPAs. So that's something which is the most heartwarming thing to notice there. These are capable people, they're living in slums, had some leadership potential, and now have taken charge of processes that can affect the well-being of a fairly sizable population. So they are the ones who plan the activities, negotiate for services, try out all things that are required for a health program. At the community level, 90 slum-level community organizations have been promoted, mostly through the effort of the cluster coordination teams with support from NGOs. And they counsel families, bring them together, mobilize all the people, and ensure that there is no unreached family in the slum. There's the special need household sometimes, if there's a woman who for some reason is suffering violence from her husband may be an alcoholic. So that family will be something like a special need family and would not itself be able to take care of health. Thus requires this extra support from the slum CBO. These are some indicators which we had from the survey, baseline versus post-intervention. And there is encouraging improvement on many indicators. In terms of impact, if you want to look at the second last indicator, that is underweight for age, has decreased from 46 to 29. And these were fairly large-scale surveys conducted by external agencies, which are engaged also by the DHS people or the NFHS in India. We also did a smaller survey to just understand maternal neonatal related issues, and here also there is improvement on some of the birth and early neonatal care related practices. On 2 such indicators which are more related to the warmth to the newborn, we unfortunately did not collect any baseline data, so you just have the purple bars. But for other indicators, we can show an improvement from baseline.
These are in the project-assisted slums, is
Yes,
that correct?
these are all in the project-assisted slums.
Do you have any data that shows for like a control area that
We do have actually this.
did it increase as well, or is it
There
stable?
has been increase in the control area as well, but the increase has been far less than in this area. We are still in the process of completely analyzing that data, so it's still not ready. The pie on the upper right-hand corner shows something interesting. When we look at home deliveries, we just aggregate all deliveries as home deliveries. An interesting thing here is that a substantial proportion of the home deliveries actually take place in the native villages. So programmatically this is crucial, because if you're running an urban slum health improvement program and say 15% or 20% deliveries are not taking place in those slums, this is an interesting challenge to deal with, at least worth noting, even if the program cannot directly do anything. Because we also did not disaggregate this in our baseline, but when we were conducting this study, it just occurred to me that we should ask and find out what the situation is on this question. The second approach, we very quickly will go over this, is the ward coordination approach. Here all the stakeholders come around for the ward, which is the administrative unit at the most basic level, or the smallest administrative unit in the city, the municipal corporation, the health department, non-government organizations, elected representatives. It's their constituency. It's important for them to nurture their constituency. The DUDA is the District Urban Development Authority. It is as part of the Ministry of Urban Development. Local schools and local clubs such as the Lions Club, the Integrated Child Development Services, So they all come together, they formed this committee in Ward 5 initially, and they identified unreached slums and then tried out various ways, improved outreach services through all existing resources. So this approach is more like a service improvement approach, more the supply side improvement approach. It does not have a community capacity building or a behavior promotion angle associated with it. So it is a low cost, low benefit type of approach. It has modest benefits, but on a smaller spectrum of indicators. And slowly everyone found this approach very attractive because it is low cost. So it has been replicated in one more ward, and so now it covers 2 wards. This is some of the data from the first ward that it was covering. It has shown some modest improvements. I think the maximum improvement is the reduction of the dropouts, which is an important thing in if anyone studies immunization closely. Dropouts is a very important phenomenon, and I think that was what it helped improve substantially. The third program approach is from Agra. This is in areas where there are no services. And the governance in Agra is far weaker than Indore. Agra is part of Uttar Pradesh, where the governance is weaker than even Madhya Pradesh. So here we tried to start NGO-managed urban health centers in areas where there were no health services. So here an NGO rents a building, hires the doctors, the auxiliary nurse midwife, which is the paramedic in India who provides most of the maternal child health care. And the NGO also does the community mobilization activities in the slums on this side. So the NGO has this whole role in this approach, and the government provides them the vaccines, the birth spacing supplies, the iron folate, and some other supplies. But government supplies are not always complete, so the NGO do complement through their own resources, because USAID money is not to be utilized for procuring medicines. So we have encouraged the NGOs to get those some drugs from some source or the other. So they do get that donated. So in Agra, through these urban health centers, we have 2 such urban health centers. One of them covers about 40,000 population, the other covers about 60,000 because it is located in an area where there is no other health service. So automatically its coverage has increased because it started with a smaller coverage, but once it got stabilized, we've added a part-time doctor to the same health center rather than setting up a new health center, which would have been more investment. We've added one more doctor, more A&Ms, and this from the same health center, they now cover about 60,000 population, a little more than 60 actually. This program is only about 2 years old, so we have not yet conducted any post-intervention study. We hope to conduct it next year, and then we should be able to find out exactly what improvement it has led to. The CLV is a slightly new nuance in Agra. These are community link volunteers that have been promoted in the slums. One volunteer for about 2,000 population, and they are trained by the NGOs as well as by the Urban Health Resource Center. And this is part of the Government of India's overall approach for urban health across the country. So hopefully once we have more experience from Agra, this will be a learning site for government officers so that they can come and see how the community link volunteers operate, how they were identified, what work they do, and probably feel more confident about applying the same approaches in their respective cities. We've been fortunate that our Indore program is being replicated by several cities. There is a city by the name of Ujjain, which is about 40 minutes from Indore, We have had 2 delegations from Ujjain to understand the Indore program, and they want to replicate it. So the basic purpose of these city-level demonstration programs is now beginning to bear fruit, that people come there, want to learn about the various approaches, and then try to apply those approaches in their respective cities. And that is how we are able to use them not only as service delivery approaches, but more as learning sites to influence other stakeholders and help other programs take advantage of the lessons that are learned here. Just a summary of the lessons. These are probably my last 2 slides. The situation analysis helps understand the city, understand the slums, the needs and opportunities. Maps, as I said, is a very crucial tool. Building slum-level institutions helps be closer to the problem and also facilitate linkage of these communities with the providers. Intersectoral linkages to address water and sanitation issues are difficult, particularly in weak governance situations like Uttar Pradesh, which Agra is an example of. In Indore, we have had some success. We have coordinated with World Vision and UN Habitat and the Indore Municipal Corporation for water, sanitation and drainage. So if anyone visits the Indore slums, some of those slums have got totally transformed by that, because they appear to become totally different. But in Agra, this is still a challenge. So I just thought of putting that as a lesson, that in weak governance situations, it's very difficult to get this off. Existing slum leaders and networks can evolve as very powerful organizations. And partnership and coordination among stakeholders can help optimize the resources. And NGOs can expand services quickly to unserved areas. So I just wanted to end with hope and confidence that public health professionals like all of us, academics, civil societies, governments, and slum communities can work together and use this long lever of commitment, motivation, knowledge of the problems, and accountability and responsibility for improved urban health governance. I've used the word governance because I think that's something which probably summarizes everything pertaining to urban health system. And a thought for all of us, that a small body of determined spirits fired by an unquenchable faith in their mission can alter the course of history. So on the one hand, while urbanization is making some changes in this scenario, probably some committed people can help address those challenges. Any guesses who this quote is from? This is from Gandhiji. Thank you.
Dr. Siddharth, thank you for an outstanding presentation, one not only filled with facts, but filled with knowledge and passion as well. And I think that long lever applies to you and your commitment to this effort over the last 5 years plus. So we really appreciate that. And I'm sure there will be a number of questions. But I'm going to hold the questions for a moment, and we'd like to hear from Dr. Diana Silimperi to provide some comment and some insights on Dr. Siddharth's presentation. Dr. Silimperi.
Thank you. Well, I have a very easy job after such an exciting and rich presentation. Clearly, I'm sure you all have lots of thoughts and questions. But I'm going to start out with taking what we just heard and going a little beyond that to application really more globally in cities, and where we've seen and heard some of those same findings where they apply more broadly than India, even as big as it is. And so I'm going to just divide my comments into 3 parts. First, I'll talk about some key points, as I said, that can certainly apply from this presentation to other urban sites. Secondly, I'm going to talk about some of the challenges, again, the global challenges, but also the opportunities that this growing urbanization of our globe means. And thirdly, I'm going to end up with some questions for you. I'm going to take a little bit of editorial license and start out with a few of what I think are some key technical questions for a very excellent presentation. So bear with me. First of all, I think it's what Vic started out with. I really like that term, Urban Crucible. That captures it very nicely, because really, take a minute and think of the implications that we are living at a time in history which is in fact unique. There has been no other period in the history of humanity in which half of the world has been urbanized. And by 2025, according to UN estimates, over 2/3 of the developing world will be living in cities. What are the implications for all of us as a human species with this massive urbanization in really a relatively short period? What are the implications in terms of our socio-cultural development? Implications on families, implication on governance, not simply implications in terms of health and health systems. I say to you, these are enormous. And quite honestly, I'm not sure that we as a civilization have even begun to come to grips with the ramification of global urbanization. Hopefully some of you in the room today will leave and take up the challenge to look more deeply into this issue and help us all begin to understand and deal with it more effectively. In the context of India and the 2, 3, 4, 5 percentages, the simple fact that those living in the slums or the bustis are increasing faster than other segments of their urban population is not unique to India. This is something we're seeing worldwide. So the fastest growing segment in cities is the poor. In other words, put simply, the poor are increasing disproportionately to the non-poor as we urbanize. Despite the fact that we think going to cities, why? The attraction for employment, for opportunity. And some of that, of course, is true. But unfortunately, if you look at the rates of growing poverty, it is not bearing true for most. What are those implications on life as we know it? Another element that we see across the globe, and I find it quite striking now, having worked and lived in Asia and Africa, and worked at least in Latin America, that the issues across cities are the same, no matter where you go. Of course, there are sociocultural differences, variations, but the key issues transcend society and are true worldwide. So we've talked about the increases. We've talked about, in fact, well, we haven't talked about, but I'd like to say that also, in fact, what we see is there's probably more links between those living in urban poverty in a developing country and those living in urban poverty in a developed country than they have with the non-poor in their same societies. So we're developing a new kind of global alliance, perhaps, unfortunately, commonalities among the urban poor. Some of data is beginning to emerge. In fact, there was a controversial study done some time ago, 10, 15 years ago, that began to compare health statistics and lifespans, for example, with people living in poverty in New York City and those living in Bangladesh, where I happened to be living at the time. And I think, in fact, we are beginning to recognize with statistics behind the statement I just made how, in fact, urban poverty and the implications on health, again, transcend societies. A very important point that you made was in terms of the economic weight of the urban poor. And this is something we have not capitalized. Those of us who are concerned about the issues of urbanization and urban health have not capitalized upon the fact that the urban poor are contributing significantly, albeit through the informal sector, but make significant contributions to the overall economic well-being of that society. And this is something that I believe can be a very strong advocacy if we quantify that more effectively and use it in terms of catching the attention of policymakers. Another important point, and fortunately with folks like Siddharth, we are getting better and better data, but we still don't have enough that captures that the urban poor, in the context of their health status, be it mortality or morbidity, as he's shown, are as bad, and in some cases worse, than the rural counterparts. Now, that doesn't mean that we should ignore the needs of the rural. Of course, we have to continue, but we have to have a two-pronged effort. We cannot continue to maintain, oh, urban, look at those aggregate numbers. The urban dwellers are doing fine. We can focus on the rural. That is simply not true. And so, thank you for showing us so clearly with your very good data, but that's also the kind of data we need from other sites. And as you indicated, it's not easy to get. And in fact, the aggregate data that we usually see, urban, rural, masks the issues of the urban poor, and we should all be advocates, in fact, to make sure that we push national sampling frames, national surveys to get urban disaggregate data. There are many issues, in fact, as to why it's hard to get that, and you noted a couple of them, including the fact of the hidden, what I call the hidden millions often, those that are living in slums that aren't, in fact, there. They're not recognized because of their lack of legality. They're not even known because they shift, as you noted. They literally, physically move from areas of the city. But there's also, so there's enumeration issues, but there are also issues, cultural issues. Who does your surveys? Those folks don't like to necessarily go in, aren't always comfortable, and sometimes it isn't safe to go in to capture the data, to collect the data from the urban poor areas. So it's a little bit of a complex issue, but it doesn't mean we shouldn't address it. The service gaps that you mentioned, again, this is going to be true globally. In the poor city among the urban poor in India, but you go to the urban poor in Nairobi, you go to the urban poor in Maputo or onward over to Latin America, you'll find the same thing. They do not have primary health care services accessible, even geographically accessible to them in many cases. We have to be very careful in urban settings because we assume that geographic proximity means access. And obviously it doesn't. You can have a road that stops you crossing it because of safety reasons, but you also have other major barriers so that even when there is a facility close to people in urban settings, there can be fears about legality, cultural issues, there can be issues in terms of the availability of services because of working hours, and of course financial barriers. So there are major issues in terms of the access and availability of services to urban poor. But in particular, and on top of that, we find that when you look at where health centers are based, they're not, by and large, concentrated where they're most needed among the urban poor populations. So there is a dearth, literally, of facilities. Cities do tend to have more hospitals, but that doesn't mean that the urban poor, again, as in fact some of your data shows, are able to use those facilities. Another issue that you tapped on a little bit, but I'd like to stress more in terms of implications globally for dealing and delivering services to the urban populations, but the urban poor. In fact, they have choices. Generally, in most cities of the world, there is a thriving informal private sector. I alluded to that earlier in the context of the economics, but it's also true in the context of delivery of health services. There's a thriving set in many countries. There's a thriving set of traditional healers that are in the cities. There are many types of drug vendors, chemists, they have many different names, but that are providing certainly medicines, antibiotics in particular. And there are, in growing numbers, literally private providers, doctors, nurses, pharmacists that are working on their own. Of course, many of them also work for the government during some of the hours of the day, but increasingly there are, general private practitioners in urban settings. So folks have more choices than they have in rural settings. And although the public facilities tend not to be focused in the urban populations, they have a lot of informal choices where they can get, maybe not quality care, but they can get care of some sort. So that needs to be taken into account, I think, when we look at really reaching, how can we better capitalize upon those available existing resources a la informal sector resources to provide services to the poor. And I don't mean suboptimal services, I mean quality services. Another issue in terms of service delivery is the fragmentation of care, in part because of the different providers. It's very hard to have a continuity of care. They can jump back and forth, but also they move, and you showed very nicely. They move within the city, but they also go back often to rural areas. Some of this is employment dependent, or they may go back to a different part of the city where they live at nighttime, but in the daytime they're providing work, care in another part of the city. So actually this fragmented care is exacerbated by the mobility of urban poor populations. So we can go on and on. I think there are specific delivery system issues in terms of reaching the urban poor effectively and in a timely manner. But we need to also be very clear about how urban delivery is different than rural delivery. There are differences. I've tried to bring that out, but I think we need to be very explicit about that and address that concretely when we develop urban health systems. We need to develop new, and in some cases, alternative delivery modes, certainly that include outreach, certainly that are grounded in the communities that are being served, such as some of the examples that Siddharth shared with us. We also probably need to recognize that some of our existing facilities, like hospitals, do serve a double need in cities. And there's been some studies, particularly in Africa, Tanzania, Ghana, that showed, in fact, the urban hospitals are providing primary health care, not because people are bypassing other facilities, but because there's a need. And they are, in fact, fulfilling a need for those populations. Let me shift a minute. There actually are a lot of opportunities as well. I've been dwelling on a lot of the complications, challenges of the growing urban population. But in fact, you alluded to, there are opportunities, and of course one of them is the fact of urban density. You've got a lot of people in a close area, so in terms of delivering services, in many ways, you can capitalize upon that. And certainly when you start looking at community-based services per numbers of population, you can reach many people in a shorter amount of time and with usually less expense and ease. There are other advantages. Urban populations are heterogeneous. They tend to be very dynamic. They tend to be people who sometimes, by virtue of circumstance, are nonetheless open to change. They often become the change agents, particularly the women. And there have been ample examples of urban volunteers, women volunteers, who become really the purveyors of change, new ideas, including those in health. They may be less bound by tradition, less bound by familial ties. That can be an offside, but it also can be an advantage. So many of the disadvantages and challenges in urban settings can be turned into something positive if we're looking with that lens. Take a quick drink here. One other advantage, and I'm sure you're going to think of some others when we get into the discussion, but another advantage is, in fact, in cities, you do more commonly have access to communications. Even if you don't own the television or radio, somewhere in that busti, you'll find someone that has one. And everyone, as many of you may know, and I know you know, will be grouped around that one set, watching the news or watching a soap opera. But the reality is that the communication modalities are something we can take advantage of in cities to reach more people with health education messages and information of where to go for services. Given the enormity of the urban crucible, why is it then that I'm sitting here almost 20 plus years since Vic and I worked together, and 20 plus years from the time a number of us became involved in recognizing the urgency of addressing the growing urbanization of the world. And it struck me as I was coming over here that on some level, many of the issues that in fact I assumed that would be raised by Siddharth, and in fact he did raise, were exactly the same that we presented in Nairobi, Vic. I was involved in a conference at the same time in Tokyo. Some people were gathering as well in Latin America. So the issues have been known. They are not new issues. Those challenges have been there, and we've begun to address them, but not successfully yet, not effectively on any scale yet. Why is that such an amazing problem that has implications for all of us, regardless of our country, regardless of our own socioeconomic status or where we live? Why is that not being addressed? Why is it so hard to get policymakers? Why is it so hard to get donors focused on the issues of addressing urban health? Let's come back to that in the discussion group. I'll share with you some thoughts, but I really would like to go beyond them. And I think that it is the major challenge. We need to go outside of the health box. We need to really reach out, not simply from the perspective of intersectoral collaboration for health, but to other sectors, to civil society, to decision makers, to economic and private business